Hello again. This is not Jack Benny talking. Welcome to the Chat with the Doc show. I'm Mo Wolf, the acupuncturist at the Siloam Center for Traditional and Integrative Medicine now in Janesville.
And I'm Dr. Noelle Margleski, the chiropractor here at the Siloam Center. So glad to be here.
And you'll notice
different space today.
Different place. Well, that's because we decided to move everything into the back office. So this is the doctor's office. So if you ever get called back here, it's probably because, well, we're full up elsewhere and we needed to stuff you back here. But this is our space. So welcome. Today is a very special day. I woke up this morning, got dressed, and my socks were falling down in my boots, which makes for a really miserable morning. And I had my cup of coffee, and I thought, there's still time to change my socks. And I did.
Yeah.
My socks are no longer falling down in my boots. It's a great day.
And it's Cinco de Mayo. And
yes,
Taco
it is.
Tuesday.
Keep your 6 foot distance.
Yes.
Hacienda Real is closed today. Well, no, you can do takeout there.
Or make it at home. Whatever works. Still, you can still celebrate. So.
Go easy on the Corona, though. I hear it's tough on you.
Yeah, definitely. So today we want to talk about the shoulder, right?
That's right.
That's
right. Today is Shoulder Day here at the Siloam Center. And keep in mind, if you're into bodybuilding and you're working on the shoulders, don't neglect leg day or you will look like a giant chicken.
That's true. So the reason we chose shoulder today, we kind of went over more supplemental stuff, but now are we close to getting back to open for the Siloam Center?
Acupuncture side and NAET side and functional side, we are open. Cool. We are limited on our intake. We can't run all 4 rooms plus people in the waiting room right now just because of safety reasons.
Right.
But we are, again, taking patients. Now, right? We're able to treat, yeah.
So we wanted to look at something a little bit more anatomical today and something that is important for you and I, what we see a lot of, because with the shoulder, it doesn't matter if you're inactive or you're very active. It seems to really hit people pretty evenly across the board with that.
And when one goes within 6 months, the other one goes.
Because you're compensating and using it to make up for the other.
Yeah.
So that's why we chose to go with the shoulder. It's relevant for both. A lot of people that do the desk posture coming forward, that's hard on them. And I'll explain why. Drivers, very active people. I know plenty of, either athletes that are in high school, college, beyond college. That's the one that seems to really get you first, I would say, would be the shoulder.
And keep in mind, keep in context the last couple shows that we did where we were talking about glyphosates and how the glyphosate replaces the glycine in that collagen production. Yeah. And now you've got a collagen fiber that is very, very brittle and tears easily with explosive movement.
So it would be the tendons and all that different stuff in your shoulders. How that would apply. The tendons,
the ligaments, the labrum, that little capsule that holds everything in place. Now that becomes very brittle because of that glyphosate presence in the body, and it's everywhere.
And that's prone to injury.
And now
you notice it.
Because of our environmental toxic load, you're prone to injury. So now you move quickly. You're going to throw a ball with your kid in the backyard. You get little micro tears.
Yep. And it's usually the small things that will throw people off. Like they come in, and it's not just in the shoulder.
How profound, Doc.
I know. It's not usually the big stuff. It's not usually the big things that will always bring people in. Sometimes it's the small things, and that can be anywhere in the body because, like we said, glyphosate will affect systemically. It's not just going to pick one piece of you and attack you. It's going to go for the whole thing.
That's right.
So that's why too. So I was going to go through a little bit of anatomy because now we know why it's relevant. Why do we even care about the shoulder? Because it's affecting a lot of different people.
If you've ever had a shoulder injury, you know why it's important. Because now half of your upper body is rendered useless. you can't use it. And it hurts, and the pain radiates downward and upward into your head.
Yep, and you realize how much you use it when it hurts.
Yeah.
So I'm going to go through the anatomy a little bit. How does that look on the screen? Can you see anything on there? Or is that going to bring it up closer?
No, you're going to want to go closer.
Okay. So I'm going to bring all these up a little bit closer. Okay. This is probably going to be backwards for you guys. I apologize. But you'll be able to tell by
there you go.
landmarks.
It looks like it's in Russian.
That's okay. Okay. So this is just to give you guys a layout of where we're at. This is looking at the back body. This would be where the shoulder blade and the spine would be through here. Then you have that curve of the shoulder. This is the actual shoulder that you feel. Then this is the back of your arm. So the rotator cuff is made up of many different muscles that attach into that cuff. The cuff actually sits right about where on your shirt would be, that little part right through here. So you can see where the rotator cuff is. The supraspinatus is one of the major injured muscles of the rotator cuff. That one sits right on the very top. Your neck sits here, so sometimes that's when you'll feel that burning through here, and it'll also radiate down into the arm. It goes right underneath this right here, so that's with the AC joint, and I'll show you on the other picture too of how that plays out. So that's sometimes why you'll feel pain farther down your arm and not always where that muscle belly starts. Another one would be Terry's.
What did you call me?
Huh?
I'm sorry.
Muscle belly. Another one is Terry's major and Terry's minor. They sit more underneath your armpit. For some people, if you poke them in that area, even if it's not very hard, for how a lot of us will end up coming forward with those rolled shoulders, it'll be very tender and they likely will not like you.
And very ropey.
Yes. Because when I work on people with that, sometimes that will bring a tear to their eye. Not going to lie.
And for people that are doing woodworking and remodeling and they're sanding, and those are the guys, those Terry's minor and Terry's major, those are the guys that tend to get really torn up.
Yeah.
And you know, if you're left-handed and you're doing that, the day afterwards you're all sore and you're thinking, did I have a heart attack? No, it's your rotator cuff.
Yep, you got to think of what you're doing. You got to put the whole thing together. And with those muscles, just like the supraspinatus, that it would refer down into the arm, that Terry's will actually sometimes refer up where that supraspinatus is. Because I've worked with people that, you know, they think this is where the pain is. They'll point to it, they'll put their finger on it, like, why are you not working here? This is where the pain is. Well, sometimes where the pain is isn't always where the problem is. So that's why you look at that whole shoulder girdle to work on it and not just hit where the pain is. So that's the first anatomy with that. That's the back side of the shoulder. Now we come to the front side of the shoulder here. So like I was saying, I'm going to reorient you here. So this is the part of the shoulder at the end. So right through here where the collarbone hits, there's that collarbone. And then you feel that little bump right here on your shoulder. That's the AC joint. Then comes down the head of the humerus, and then you have your bicep there, bicep. You have your bicep tendon that comes down through there where you feel the belly of the muscle, where the gun show comes from.
Yeah.
So looking at this, supraspinatus sits right here. You saw it in the other one from the back side. It goes under that AC joint and connects to the head of that humerus. So sometimes that's why you'll feel that pain referred down into that arm through there. So that's a very common one. So is bicep tendon. That one you'll feel sometimes when people actually tear that, you'll either see bruising or you'll see like a little ball kind of sitting at the top where the bicep should be, and it's very painful. But there's also some orthopedic tests you could check for that too if you're not getting those visual referrals for it, because not everybody injures themselves that badly, but if you really do it good, you can see it. So that's a little bit of orientation. There's other parts of it as well. Like AC joint is a big part of it. The collarbone and the clavicle is a big part too that people have shoulder pain with. If you get the muscle balance or the joints off balance, you will feel it in different aspects. I see it a lot lately with the collarbone coming in. There's a lot of pain through there, and I'll explain why you can get some of that pain too when you're having problems with your shoulder. So that's just kind of a general outlook on the shoulder there. Also, this is where that rotator cuff comes. You can see where these are crossing over that's what forms that rotator cuff. And then you have that capsule that holds together the arm to the shoulder.
The common misconception is that the rotator cuff is one structure.
Yeah.
The rotator cuff is not one structure. It's a number of different structures,
Yes.
all working together to stabilize that shoulder joint.
And give it mobility too.
Yep.
Because we don't have mobility as much in our hip as we do our shoulder. That's why we have all those different connections. So
Well, it's that ball and socket
Yeah.
that doesn't have much to keep it in place.
Yep.
The hip joint is the acetabulum is much deeper for that
Yeah.
trochanter to lock into.
It's more stable for us.
It's more stable structurally. The shoulder's wide open.
Yeah.
And so God designed the shoulder with these beautiful flexible pulleys and ropes to stabilize it. And
Give
then
it mobility. Yep.
and then put that labrum over it to hold it all together.
Exactly.
And so you've got stability, but you've got mobility at the same time, which is a very interesting paradox when
It
you think
is.
about this, the tensegrity of that shoulder.
It is. And that too gives more room for injury to occur. But at least we have more than just one connection for rotator cuff. So let's say you have one piece of it go, at least you still have other parts of that cuff that are holding you together so your arm just doesn't start hanging down. That's why people can have rotator cuff injuries for years, play basketball, do all these different things. Maybe they feel burning, but they can still keep going because maybe only a piece of it is torn until they get to the point that they get more extensive of a tear and then they want to get treatment or
And
it's to that point.
You go into the Western world, you go into the allopathic world, and what's the first thing they want to do? They want to do physical therapy. Well, if there's tears, the physical therapy, depending on the intensity of the tear, the physical therapy is not going to do a whole lot.
They're more looking if there's, structural stability that they can bring them through to try to avoid it
Right.
at this point. That's
So
what you'll
then
see
what
on-
happens is, oh, you got to have surgery. No, you don't. Most of the time, you don't. Your techniques work really well. Acupuncture, gua sha, the cupping when done at the right timing.
Yep.
You don't want to do the gua sha and the cupping too early, and you don't want to do it too late. It's got to be done in the correct timing. When these things are done correctly,
usually can get healing.
you usually can get that structure to repair.
So that's why we look at the shoulder with that as well. So if it's also, we have the muscle aspect of it with the joints, but then we're also throwing the nerve aspect in it
Mhm.
as well. So in the shoulder, we also have the nerves of the neck or the cervical spine that come down and create this brachial plexus or this big massive nerves that flow down into the arm and the fingers. So sometimes also you're having pain up in that shoulder, but it's not always just the shoulder. It can be your neck as well because they're so closely connected. They share some of the same muscles. They share some of the same muscles. So a lot of times when I work on this stuff, it's not just one single thing we're working on. Wish things were that easy. Usually things are more, if you got one thing, you got at least one or two other things that are going along with this.
Well, and you think about that. In Chinese medicine, we have the vessels.
Mhm.
You have the various different vessels, all associated with organs. You might have heard them referred to as meridians or channels. But each one of them is paired and influences the others. So you've got the small intestine vessel in the back that comes up right here and circles around the scapula and then comes up. You've got the sanjiao, which comes up along the outside of the shoulder. You've got the Yangming, the large intestine. You've got the Tai Yin, the lung, all the way around. And each one of these vessels and going to be areas of weakness. And you'll see people with severe long history of allergies.
Yeah.
They get that pain in their shoulder injury referring down the deltoid, down the outside. And it's not just the one area because the whole digestive tract is involved. And so as crazy as it sounds in Chinese, we basically treat all of those digestive vessels around the shoulder.
That's too why some people will come in to see you, maybe just for the shoulder and neck pain, let's say.
Mhm.
they'll get a treatment from you and they're like, wow,
my irritable bowel's gone.
It's really good. Like,
yeah.
What did Dr. Mo do?
Yeah.
He treated you as a person. He didn't just treat your symptoms.
Which again goes back to what we've been harping on almost every show, and that is having the right practitioner that is looking at the whole, not somebody that's going to have a list of symptoms that we're checking you off for and say, oh, you fit this box, this is the procedure that we do. No, Dr. Noel, myself, we're going to be looking at what all is involved and what is being affected by the injury or the emotional issue.
Yeah.
Because we treat it all.
That's right. We treat it all. And then get back with the vessels, like you explained. A lot of times they do flow with the nerves. Mm-hmm. So when I go over with the nerves, almost always you'll see a vein and an artery that flow with nerves together. So they all kind of hit that same range. That's why our therapies complement each other, because they're working on the same things together synergistically. So. Ooh. For Tuesday, who would have guessed? So, all right, so I'm going to come a little bit closer and go through it. So, what it is showing here? Let's see if I can get it in the light.
You got it.
Okay, so this is all in grayscale, so it's a little easier to see it in color. If you would ever want to take a little bit deeper of a look, let's say before you want to call us, so that you just have an idea, if you're considering coming in for treatment but want to do a little bit more research on your own, type in cervical dermatomes or type in thoracic lumbar dermatomes, and you're going to see this in color and you'll get to trace it out. So I'm going to go, this is the back of the body here. So each of these dermatomes represents a nerve root that comes right back to the spine. So these nerves, they don't really run. I tell people when they come in all the time, nerves don't really run like spaghetti noodles, like straight up to, the sensory, the organ, the muscle that they connect to. It's more like a spider web. Mm-hmm. But these are good representations of, in general, how they follow, how the pain paths follow or the sensory paths follow. So way up high in the back of your head, sometimes people get the headaches that go onto the very, very top of their head. That's the C2 dermatome, or very high up into the neck. So then you start coming down. So once you hit a little bit lower into the neck, past that first bump you can feel, that's C3. That goes more at the base of your skull. So sometimes people will always have pain there, and it's not always right underneath it. It can be a little bit deeper under, because it's not always, like I said with the shoulder, where the pain is, where the problem is, aren't always the same spot. Then as you head further down into the neck, you start to get these nerves running down into the arms. And like I said before, with that brachial plexus, this is where that comes into play. So when you have pain, let's say running down your shoulder here, and maybe it's going into your thumb that you notice it, or tingling, numbness, that can be the nerve coming from the spine there. And then you go further down. Very commonly I'll see them where it's more at the smaller fingers of the hand here, and that's usually lower into the neck that you'll feel that. And it can be a burning sensation, it can be a numbing sensation. So, it just shows it in the front that you're going down here with the lower ones. As you go higher, you're getting more into the neck.
And people will feel that discomfort and they'll come in and say, I have carpal tunnel.
Yes.
You test them for carpal tunnel, you do the orthopedic exam, and it's negative. Mm-hmm. And so then a good practitioner is going to be following those dermatomes and looking for nerve impingement along those dermatomes coming all the way up.
Exactly.
And it's usually the shoulder.
Usually is. Sometimes you'll get it lower and you'll shoot it up high. I think it's double crush injury with that, where you'll find more.
Sounds like a band from the 80s, and dermatomes sound like a band from the 60s.
We're just keeping it fun on it.
I tell you what, gosh and gollies, let's all sing in harmony.
So those are some of the nerves that come through, and how those play into this too, and why sometimes when you come in with a shoulder injury, it's not always just straight up the shoulder. We'll be looking into the neck or the cervical spine, and we might be treating that in conjunction with the shoulder. I'm going to show you one more. So the joints also in the neck can give their own referral points. You can kind of see it, and this plays up more. A lot of you have had that pain that goes into the shoulder right about there, behind the shoulder blade. That's a big one. That one's also at the base of the neck. Then you go up higher, it hits the top of the shoulder. That's a very common one. That's in the middle of the neck. So if you're doing more looking forward, or let's say you're a mechanic and you're looking up from the creeper on there, you're hitting more of the middle of your neck, and it's hitting a lot more of that, that weight. So you'll start to get that pain referring down. So those are different spaces too, where you're gonna notice those nerve pain referrals. So, so that's with those. I'm gonna show you guys one more thing, and then we'll chat a little bit more and maybe do some tests so we can prove for that. So a lot of us have what we call upper cross syndrome. I'm going to show it to you. First, I'm going to show it to you in person. A lot of students are a good example of upper cross syndrome. And it's where, when you see them walking, and a lot of the kids on the phones, you'll see it too.
Yeah.
They start to do this. They'll come forward with their head that they're almost like, I can't even do it as good as some of the
And then the back
can.
slouches
Yes.
even more to compensate.
Because if you're standing up straight and doing this, it doesn't feel good. So you got to get both going, if you're doing it wrong. So when you do that, when you're coming forward and hanging your head, looking down at a device like that, you're weakening these muscles in the front. You're overworking these muscles in the back. And then it also goes for not just your neck, but lower. So you're coming in, getting tighter in the front. Your pecs are getting super tight while it's pulling on your back.
And those core muscles are beginning to become asymmetrical in strength.
Yes. The core gets loose. Gets off. The glutes get weak. The hip flexors get tight. The core starts to lose its tonicity.
When you have asymmetrical tone, muscle tone in the body, you're going to have a problem. Think of a suspension bridge with some of the cables being tight and some of them being loose. Do you really want to drive across that?
It's going to be like Indiana Jones. Temple of Doom. Probably.
I'm drawing a blank, but probably. It's not going to end well.
No, and same with that. It's not usually the areas of weakness that you'll notice a problem. It's the areas that are overworking.
Yeah.
A lot of people, I guarantee you, at least 70% of you, if I would put one finger on your forehead, you would not be able to resist me because your neck muscles are so weak.
Yeah.
Mo, probably not one of those people because
you say the sweetest things.
he could take you down.
But
But that's a whole different training though that a lot of people don't do to strengthen that.
Yeah.
So I'll show you on this picture here. Okay, so this is how we should be standing when your shoulders are rolled back together. It's good there, you're more in line. That's a good posture. If you start to come here where the head comes forward, the hips and that start to sway like we just talked about before. So it explains it here. You get the tight muscles in the back so that levator scapula is the top of that shoulder. The traps is that big, very big muscle in the back that everybody notices. It looks almost like a diamond shape. So it starts at the neck, goes out to the shoulders, and feeds into the lower back. That tightens up. And then in opposite for the front here, you're going to get, the front of your neck here is going to be weak. It's not working. So that's a big part of it, why you feel that burn through here. Also in the front, if you want to look at something that's going to end up being tight from coming forward, it's going to be your pecs or your chest. If that gets tight, you're also going to notice it in the back because that's being tense and pulling. And then you're also going to have weakness in the lower traps and then the serratus anterior that's like these little, looks like little fingers that come out in the really ripped guys.
The Bruce Lee muscle.
Yes. So that's the common upper cross syndrome that we see a lot. It's kind of part of the modern lifestyle with that.
Yeah.
Okay. So those are the things that we're looking for when people do come in at just the first glance. When we're working with people, we can pretty much tell that probably within the first few minutes. You look at their presentation, they come in, they're hunched over doing their paperwork, and then you work on them. Maybe they'll try to straighten up for you, but you can tell with that. So then we go into our next step with that. We'll do some orthopedics, might do some reflexes.
Are you going to do an Ethel Merman impersonation?
Come on.
I'll take that pause as a no.
Can't go back so far. I don't know. Anyways, We might do some reflexes, might do some range of motion, orthopedic tests, all those different things to see, do we have some nerve detriments? Is it more the muscle imbalance? Do we have some tears going on?
Once these things are identified, once the injury is understood and where the effects of this injury are going in the body, then you develop a treatment plan. You're going to be developing adjustments and whatever else you need to throw at that, possibly some anti-inflammatory herbs and supplements. I will determine where the needles need to be placed in the body, what vessels are sick that need to be treated. I will add the appropriate herbs to do the anti-inflammatory, to do the pain reduction. But that pain's going to change. And that pain is, you're unwrapping a tangled mess is what you're doing.
Yes.
And so that pain is going to change, where you might have had pain right along the deltoid before in that Yang Ming Sanjiao pain. It might become all tie-in pain in that pectoralis for the next visit, and then it might go back.
Yeah.
So what practitioners will often say is, well, I want you to alternate ice and cold, or I'm sorry, ice and heat. Alternating ice and cold would be pretty boring, wouldn't it? One of the things I always caution patients on, particularly in the shoulder area with the brachial plexus, with all of those nerves in that area, and because it's probably a non-vascular tissue that's in play, the ligaments, the tendons, the labrum, don't use ice. You don't want to use ice after the first 36 hours of the injury, according to the American Journal of Sports Medicine. They began reporting that in 1994, and they've said it multiple times ever since. Within the first 36 hours of injury, sure, you can use a little ice, but after that, don't use ice. Why? Because that non-vascular tissue gets damaged by the cold. And so these areas, you're better off using some sort of a topical liniment. I know you like BioFreeze.
Yep.
I don't. I've got an axe to grind against BioFreeze, but that's why you've got two different practitioners. I like, for the non-vascular tissues, a Chinese liniment called Zhenggu Shui. It's fun to say, number one. Number two, you walk into a Chinese restaurant and you'd say, I'll take some Zhenggu Shui. They'll know what you're talking about and say, sorry, we don't sell that here. But it's very calming to that tissue, and it's not only calming and pain reducing, but it's also going to be nutritive to that tissue to help it
Bring the
heal.
blood flow on that, right?
Yeah.
They say more ice in the first, I hear like more 24 hours when you have a new injury.
Right.
Because it's inflamed.
Right.
Once you start to get that, like you said, you want to get the blood flow there, but you don't want to do it too soon, because sometimes you can prolong that.
Yeah.
But once you hit that point where, usually by the time you are coming to see us, they're probably past that. That's 24-hour span, unless they're a really good patient. We've trained them well. But if it's been a while too, and it's more when we've determined it's a lot with the muscular and vascular, then like you said, heat's great for that.
Yeah.
So.
And you'll know, because the heat will either make it feel better or make it feel worse. The cold will make it feel better or make it feel worse. But even particularly around the brachial plexus, even if cold's making it feel better, don't use the cold. You're going to damage those nerves.
Not right over it. Yep. All right. So we got that. We're hitting a lot of stuff today.
We are. We actually sound intelligent. Well, you always do. This is a good show.
We got a lot going on here. It's good. All right. So like we said, we have the different treatments. There's different orthopedic tests that you can do. The two common ones that I work with, that I see a lot of, are the supraspinatus and the bicep tendon. So two easy ways to check for that one would be kind of like your muscle testing that you do. You really gave my supraspinatus a workout a few weeks ago.
Well,
I maybe have a little issue with it after that. So
and we just got to treat it.
Yeah, we do. So it's that thumb down position, just like his testing says, resist. And if you feel a little bit of, it could even be pain down through here. It could be pain up here. That's where the weakness in that supraspinatus lies. That's a very common one. Another one is the bicep tendon. So if you make, the bicep.
You make the bicep girl.
So it has to stick somewhere into the shoulder there. It has to latch on. That bicep tendon's right through here. So a good one that we use is somebody raises their hand, try to resist it. If there's something wrong with that in here, you're going to feel it zing almost exactly.
It's not going to feel good.
No. So those are two really, really simple ones to find. Also with the teres in the back here, you'll see a lot with, oh, good, you can see me. You'll see it a lot with wing scapula where they come out because people are rolling it in. Well, the scapula have to go out instead of coming in and back. So that'll get tight through there. You can see that when they do shoulder range of motion, if they get a little bit hung up going through and it's not smooth. That's a big area with the teres as well.
Well, and you've got the subscapularis, which you see in a lot of athletes. You see in a lot of people that are physical laborers that are always moving their arms above their hands, their arms above their heads. That's what I'm trying to say. Like guys that are working in cutting trees and what have you. And it's not necessarily that it's a full-blown tear in that subscapularis muscle. It can be that there's adhesions, little collagen pockets that the body's laid down to glue together the muscle fibers, and it's kind of gluing that subscapularis muscle to the serratus anterior.
It's trying to give it more stability. That's what the body's intention is for it, but it ends up giving
trying to increase mechanical advantage.
Yes.
Think in terms of pulleys. And if one rope is a little frayed, well, let's just glue it together so that we have that increased mechanical advantage again.
Exactly.
So I'm sorry.
I was going to say, and then you go further on, you think of arthritis, and it's the same deal.
Yeah.
The body's trying to give stability.
Yeah.
But don't go that far. Let us help you first.
Back up.
Anyways.
Back up.
Back to you, Mo.
Well, and that also brings up the issue of so many times. I was just talking to a lady this morning. Swollen knuckle. She was wondering what that was. Someone had told her that it was arthritis. And I said, well, it is arthritis. But the question isn't, is it arthritis or not? The question is, what's causing it? Well, you've got rheumatoid arthritis. You've got osteoarthritis. Okay, I understand that. But what's triggered it? There's always a trigger. I don't care if you're genetically predisposed to something. What turned the genes on? So oftentimes, especially when you see those swollen hot knuckles, those swollen hot joints, allopathic medicine does a really good job treating those with erythromycin. Erythromycin is an antibiotic. Why? Because it's probably
it's eating it up.
An anaerobic bacterial infection like Bartonella or Lyme. And so you've got to treat the infection to clear those things. So just because you've been diagnosed with a diagnosis of arthritis, now's the time to dig in and find out what's actually causing that arthritis.
Chemically, what's going on inside.
And I'm sorry to rabbit hole, but
that's great. But even like osteoarthritis, if you're continually doing something repetitively and you're putting stress on that joint, the body's going to try to stabilize it. Just like we said with the shoulder. Like it'll start with making adhesions to make it a little bit more strong at the time, short term, so that you can chop those tree limbs or anything like that if it's like a city worker. Or, you go farther down the line and now they take an x-ray, let's say 10, 12 years down the road and you got a bone spur in there. It's like, well, where did this come from? It wasn't that it happened maybe 2 weeks when you noticed the pain. This was happening, a decade ago.
This has been building. Those osteocytes have been building things up. Osteoblasts elsewhere have been tearing bone tissue down and restructuring. Bones are not dead. People think a bone is done. No, a bone is a living tissue that's got cells designed to move structure around to respond to stimulus.
Yep.
So if your lifestyle changes and you're now more active, your bones are actually going to restructure to meet that need.
They're always breaking down and reforming.
That's right.
When people get older you want to have that exercise where you're pounding the pavement, doing some, for your bones, so you don't end up with osteoarthritis.
So if your bones are always breaking down and rebuilding, is a bone spur a permanent diagnosis? This is a trick question.
A lot of times people are not patient enough to
Right.
go through to make it not. That's where it makes it challenging.
It becomes a permanent diagnosis where, we got to go in and we got to take our DeWalt grinder that the FDA approved and grind that off. It becomes a permanent diagnosis when you just don't take the time to utilize the proper nutrition, to utilize the proper exercise, the proper treatment, to retrain that body, to dissolve that tissue, that bone spur, and move it somewhere where it's going to be helpful.
Because if you don't change that stimuli, the process will continue.
And what's interesting is people that have cold sores chronically, chronic herpes infection, and they're taking L-lysine, which is great for keeping the herpes at bay, but that L-lysine causes the body to repack that calcium around in ways that you end up with bone spurs.
Mm-hmm.
So when I'm treating somebody and I find out they're taking L-lysine and I say, well, how long have you been? 10 years. Okay. Well, guess what? I think you probably have some bone spurs that we got to deal with.
And you got to think, when something is a process from going to, you're in your 20s, you're great, and now let's say you hit your 40s and you're hurting. That was a long process.
Mm-hmm.
You can't think about it and expect to come in for even like 6 months and expect you're going to be boom 100%. It's a healing process.
The standard rule with regards to measuring care is for every year of chronicity of your injury or illness, you want to plan on a month to 2 months of healing.
Mm-hmm.
So if you've been injured for a year, it's going to take at least a month to 2 months to get you rolling back. Not necessarily 100%, because it depends on the injury.
Mm-hmm.
Some injuries are going to be, if you've blown a rotator cuff and we're working on it, it could take a good year and a half to get that 100%.
Mm-hmm.
But for some of these arthritic issues, for some of these pain issues, to get it rolled back, you're looking at a month to 2 months for every year of injury. So my rotators that I blew out in my 20s, I could be looking at 2 years to really get them perfect again.
Not saying you're not going to feel better in the process.
Correct.
But healing, when you go down to it, sometimes, like you said, sometimes it will move.
Mm-hmm.
Like the pain will move. You'll feel like you're stepping backwards. It's not always stepping backwards. It's just going to that next layer that you're healing to get better. We're really rambling today. We're doing good.
I don't know. I think this has been a good conversation.
It has.
By the way, if you have any questions, feel free to inject them into the either the Facebook page or into our live chat on the right side of your screen. I might not see it if you do it in the Facebook, but I'll definitely see it if you do it in the live chat. So I'm going to bring Facebook up on this so that way, if there is an issue, we can see it.
And then also, I was just going to go over a few things that I can do with treatment. We kind of touched on that a little bit. Most times I will not only adjust the shoulder after I assessed it and making sure it's safe to do so. I'll adjust the shoulder, I'll adjust the neck, the mid-back, everything that plays into with that shoulder. If you just want to really focus in on one, it's better if you do the whole body as a system, that you're adjusting the whole thing to balance out. Because like we talked with the upper and lower cross, if you got upper cross going, you got lower cross going too. So you have to work on the whole body as a whole, not really spot treating.
Well, everything is tied to another piece.
Mm-hmm.
When you think of that spider web up there in the corner and you put a stick in it and you start to turn it, the whole web contorts.
Yes.
So when I am treating somebody who's got, say they've got a coccyx that's out to the one side or the other, one of the great little clinical nuggets that I was taught by a good friend of mine, Dr. Luke Laga over in Milwaukee, and he'd say, "I'm not a doctor." In other states, you would be, Luke. You should be. what he has taught me is you feel for that real ropey serratus anterior, and you agitate it while pressing on that coccyx. That coccyx goes back in line. Why? Because the tissues are connected, and you stimulate one and it distracts the other. It's not that it's distracting the brain. You're actually distracting the tissue.
I think you almost did that, not quite with that one, but was it our first video when you were showing with GI help that you were doing not only like the shin, but you were also working on the shoulder, equal and opposite, that they play together very nicely. So
yes.
that's
you
how it
are
works with it too.
Not a system of nuts and bolts. You're a very integrated system that is dependent on every other, not just every other part, but every other cell is dependent on every other cell. The cells communicate. The tissues communicate. That's why hormones are in the body. It's for communicating with the other tissues and cells. That's why the organelles subcellularly communicate with each other, not just in the immediate cell, but the mitochondria across the body will communicate with each other. You're phenomenally made.
It's pretty cool.
Sorry, I'm geeking out.
No, it's really cool when you think about it, though. Like, that's why we treat you as a whole and not spot treating. That's not our favorite thing to do.
No.
So there's different ways with adjusting. We kind of talked about that before. I'll adjust by hand, but that's not the only way to treat. I have different options with my table that instead of the snap, crackle, pop, you can do a little bit more of opening the discs gradually through flexion distraction technique. I stole yours.
That's fine.
But I also use an activator as well.
That's the very short chiropractor's pogo stick.
Yep. I was gonna make it pop. I was like, I won't fire it into nothing. But there's different ways to do it. Just like our bodies change through time, from an infant to an adolescent to, let's say, elderly, you adapt it to the person. I don't treat them all the same. There's no way I can treat them all the same.
Well, and you don't treat two elderly people the same.
No. So they can have very different lives prior to that.
They can have the exact same injury and need totally different treatment.
Yes. Because it could be, a school teacher that had more of a desk work and they weren't as active, and it could be a Vietnam vet. They both have it, same age, very different precursors that brought them in.
One of the reasons that I was so grateful to the Lord for sending me my mentor and teaching me how to treat all of my patients face up was because of a Vietnam vet. Poor guy had PTSD. They didn't know what PTSD was back then. This guy learned to just soldier through it. But you couldn't treat him face down. The poor guy hated being face down. It drove him nuts. He needed to be able to see what was coming into that room. I was so grateful to be able to learn how to treat anything. So let the patient face up so that they can see what's coming. That's one of those little clinical nuggets that you have to learn so that you can serve your patient. So you've got to find a practitioner that's not, the science of this is astounding, isn't it? Or I've got myself a career and I can't wait to get out there and play golf. No, you want a practitioner who, we are in this to serve you because this is our calling. This isn't, we didn't fill out some test when we were in high school and find out we should have been a practitioner. That test said I should have been either a farmer or a forester.
I was supposed to be a bus driving farmer. That's what it is. If you end up farmer on your test, that's got to be it. Because working with your hands, farmer.
There was a kid, and this is totally off topic, but it reminded me of it. There was a kid who was in school, and it was a 6th grade class, and you were supposed to stand up and say what your father did for a living and spell it. And so little girl gets up and, my daddy's a banker, banker, banker. Okay, thank you. Another kid gets up, my dad's an osteopath, OST. Jimmy, sit down. Another kid gets up. Vincent, what is your dad? My dad's a bookie. He spells it, and he says, my dad will give you 10 to 1 that Jimmy can't spell osteopath. There you go.
I like that. That's pretty good.
And you'll note, I didn't spell bookie.
No, you did not. You just
that's
bait
called
and
a
switch,
cop-out.
right? Bait and switch. So yeah, now I got a train of thought. Anyways, those are it's okay. There's different ways to treat somebody. I think that's how we started with this. I also like, and I think you use it as well, kinesio tape to help support our work.
And it helps stabilize that joint while providing the mobility.
Yes. So I'm not going to stick it on Dr. Mo here, but I'm going to kind of show the areas that you would normally do for a shoulder. So we'll do it towards
face forward or back?
We're good right there. I think we can show it from there. So I'll start from the top. I'll do a little bit of pull through here, stabilize it, because what you're looking for is to get it back like that. A lot of us go forward. You want to undo that. That's not going to help you any. So you bring it back. You're not doing a lot of pull. It's just enough to support. And then you go around the head of the humerus and you bring that back. And then you're getting back and in. So that's what I like to do for mine.
Well, and it depends on the injury.
Yes.
It depends on the injury.
That's
because
typical, but yeah.
Because if it's super spinatus, you want to go along with that muscle and try to just bring that tissue up.
Yep.
And it's
here, do you want to show it on me?
It's amazing. No, that's okay. It's amazing to me. When this stuff first came out, I thought, what a gimmick. How does a Band-Aid on the skin affect? Well, wait a minute. It's amazing to see how putting a little bit of tension on the skin above, which is connected to the fascial layer, which then is connected to the musculature. It's amazing to see how this little tape right here, which is flexi, can make such a big difference.
And it helps with blood flow too. And that's what you're looking for as well, to feed the muscle, to help for the injury recovery.
Several years ago, I had 5 busted ribs. And I couldn't take off of work. And Dee, if you're watching, thank you, by the way. But I had my buddy, Dr. Damiani, who was working here at the time. He's in Italy now, serving in Rome. I had him tape up my ribs. This stuff is great for even stabilizing a busted or fractured bone. Ribs are something that, no, you're not going to splint. But this tape helps to stabilize even that bone tissue. And I could work between the tape and Chinese herbs. The number one, they healed up very quickly. Number two, I didn't miss a day of work with busted ribs.
Yep, and they weren't displaced or anything. And if you would have went into, let's say, an MD, or you would have went into the ER, if they're not displaced, that they're worried about it hitting lung tissue or organ, they're really not going to do anything for you. They don't want to brace you like they used to do, because that can cause pneumonia. They'll, in that case, they probably would have sent you home. Maybe gave you some opioids or some kind of a
put me on opioids and said, come see us every couple times a week to make sure you're not getting hooked on this stuff. But that also leads us, you mentioned blood flow. When you're dealing with these non-vascular tissues, by definition, there's no blood going into them. So how do you increase blood flow to them?
Stimulate them.
Move them. So you've seen, if you've looked around on our YouTube channel, you'll see some Qigong exercises. There was one Qigong exercise that I demonstrate on there that was actually developed by one of my doctors, that instructing doctors in med school, Dr. Burns. He was a doctor of physical therapy. He's a doctor of Chinese medicine. The guy developed this specifically for shoulder injuries, this Qigong sequence. It's beautiful, and it works. And it works better, in his opinion, as a physical therapist than the exercises that he used to hand out, which is why for shoulder injuries, for a lot of my patients, I say, go to our YouTube site, walk through that exercise with them.
The shoulders is so complex too, because you don't want to make it that you're immobilizing it either.
That's
in cases. That's why you do the exercises.
Otherwise, you end up with frozen shoulder.
Yes. And then you have to break up the adhesions. That's not comfortable.
Yeah.
To bring it back. So come and to us if you have a shoulder injury. It's complex. There's a lot to it.
Sooner than later.
Yes.
And I hate to borrow a line from somebody, but once again, you've wasted a perfectly good hour.
Good stuff, though.
Good stuff. If you have any questions, feel free to contact us via the YouTube comments, via Facebook. Email us, info@sulomcenter.com. We're always interested if you've got any suggestions for content. And no, we got someone emailing. I didn't tell you this. I got somebody emailing this week saying, you guys need to talk about coffee enemas and demonstrate it. No, I flatly refuse.
Come on, you guys. Come on.
If you have any questions, feel free to send us to us. If you have any suggestions for content, let us know. We're glad to oblige. So, another good show. These are getting better and better, I think. Doc, thanks again.
Thank you.
And thank you for joining us. Shalom and have a great week. Be well.
Bye, guys.